Contrast-induced nephropathy is defined as elevation of serum creatinine of more than 25% or absolute value of more than equal to 0.5 milligram per deciliter from baseline within 40 to 72 hours. Incidence varies from 0 to 24% depending on present risk factor like diabetes, ACS, age. And regarding prevention of sin, according to the ACC-HA guideline, adequate preparatory hydration is class 1 recommendation. And short-term high-dose statin therapy in patients with moderate severe CKD is class 2A recommendation. However, despite following the current guideline, it remains a common issue following PCI. There are various studies of Nicorandil done for CIN prevention, but results are inconsistent. Regarding drug Ranolazine, there has been only one study for sin prevention that has been done on mouse model. Till date, in world literature, there has been no study done on human beings. These are the proposed mechanism of Ranolazine for sin prevention. So there is physiological possibility as well as plausibility that Ranolazine may be protective against sin in human being also. So we conducted a study to evaluate efficacy of Nicorandil plus hydration and Ranolazine plus hydration versus hydration alone in preventing sin in patients with mild to moderate renal dysfunction undergoing elective PCI. Our study was randomized controlled pilot study, a study period conducted from July 2021 to December 2022, total 18 months, and sample size was 315. Inclusion criteria were age more than 18 years, patient plan for elective PCI because we have to give hydration also, and eGFR between 30 to 89 ml per minute. Exclusion criteria were eGFR less than 30 ml per minute, NYHA class 4, EF less than 30%, and patient with hypotension or cardiac shock were excluded from our study. 510 CAD patients were screened. 315 eligible patients were randomized in 1:1:1 ratio in control group, Nicorandil group, Ranolazine group. In control group, patients received IV hydration at a rate of 1 ml per kg per hour from 6 hours before procedure to 12 hours after procedure. For patients having EF less than 45%, rate was 0.5 ml per kg per hour. In Nicorandil group, patient received tablet Nicorandil 10 mg TDS 1 day before procedure and for 2 days after PCI in addition to hydration. In group 3, Ranolazine group, patient received 1000 mg BD 1 day before procedure and for 2 days after PCI in addition to hydration. Isosmolar VCPEC contrast agent was used for all patients, and geographic characteristics and procedural information were recorded, and blood samples were collected 24 hours before PCI and 24, 48, and 72 hours after PCI for serum creatinine, BUN, and CRP level. Primary outcome was to assess protective effect of Nicorandil and Ranolazine against sin in patients with mild to moderate renal dysfunction who are undergoing for elective PCI. And secondary outcome was to measure changes in blood urea nitrogen, serum creatinine, and eGFR within 40 to 72 hours after procedure. Regarding result, our baseline characteristics were almost matched in the three groups with eGFR except eGFR, for which we have applied covariate analysis. Mean age was around 60 years, mean eGFR was around 63, mean serum creatinine was around 1.28 milligram per deciliter, and qualitative measures like diabetes, hypertension were matched in both the groups. Amount of contrast and number of stents were almost matched in all the groups, and majority of patients in each group were of anterior wall MI at the time of diagnosis. Our primary outcome was to measure protective effect of sin against this drug. Sin reduction with these drugs were statistically significant with p-value of 0.012. And pairwise comparison among the group also showed statistically significant even after applying Bonferroni correction. Our secondary outcome was to measure difference in mean serum creatinine between 40 to 72 hours from baseline post-procedure. This data also shows a statistically significant value with p-value 0.018, and pairwise comparison across the group, Nicorandil shows statistically significant, and Ranolazine, there was towards positive trend towards Ranolazine. CRP at 72 hours, there was statistically insignificant across this group of CRP at 72 hours. Several studies have investigated potential role of Nicorandil in sin prevention, but results are inconsistent. Our study showed a statistically significant risk reduction of 58% in Nicorandil with p-value of 0.023 and 63% in Ranolazine versus control with p-value 0.012 for sin prevention. Increase in serum creatinine was significantly lower in Nicorandil group when compared to control with p-value 0.03, and there was a trend towards reduction in Ranolazine group also with p-value 0.06. When we compare the two drugs, headache and hypotension are common with Nicorandil and these are rare with Ranolazine. Regarding dosing for sin prevention, Nicorandil is tedious and while Ranolazine it is BD. And regarding renal protection, both have equal efficacy. Our study is the first study to assess the efficacy of Ranolazine in preventing sin in human beings. Nicorandil and Ranolazine have protective effect against sin. Efficacy of Ranolazine in protecting against sin has been established in world literature for the first time. So we can conclude that in high-risk patients like diabetes with ACS and having renal dysfunction, undergoing coronary intervention, pre-procedural Ranolazine can be routinely added to prevent contrast-induced nephropathy.